Assalamu
The
alaikum.
podium is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the invitation. So Muhammad did mention some of what I'm going to talk about today. So let's begin with a case. So this is a 60-year-old female with diabetes, obesity, and AFib for the 2 years on rivaroxaban and metoprolol. Ejection fraction is 50%. She failed catheter ablation therapy 1 year ago, and this patient had multiple hospitalization with symptomatic AFib during the past year, GI bleed that was resolved, and currently hospitalized with shortness of breath. And this is the ECG for the patient. So we need to basically know what is the prognosis for this patient and what we need to do: medical management, catheter intervention, or surgical intervention. So the objective today is to discuss the survival of AFib and survival in AFib, and also review the current guidelines and outcome of atrial fibrillation surgery. It is a bigger problem nowadays, AFib. The global prevalence is about in 60 million cases. This is in the Nature in 2023. And this contributes to probably more than 8 million disability-adjusted life years, and the lifetime risk is more than 33%. And in this study, 2015, in the Lancet, the AFib is a bigger problem. Nowadays, with the treatment, it is a little bit better, but still the survival is very low, even at this era. And with men and women, still it's a big problem, and it's more a problem with the females. This study was published in the European Society of Cardiology 2013. And when you have an event like heart failure or MI or recent stroke, the death rate is very high, as you see in the upper curve. So in summary, among non-fatal non-clinical events in patients with incident AFib, heart failure was the most common event. And after new diagnosis of AFib, the risk of heart failure hospitalization was more than twofold greater than the risk of stroke over 5 years. So what is the current evidence, and what's the current guidelines? We all know the 2017 clinical practice guidelines. Nowadays, we have 2023, just came a few months ago. And today, we're going to talk about the first part of it, so mitral valve operations and concomitant surgical ablation. This is one of the trials, randomized control trial that was done by Dr. Margarinov in Cleveland Clinic and his colleagues. Muhammad mentioned this as well. So the patient randomized into either surgical ablation or no ablation. And as you can see here, so the freedom from AFib was significantly more in patients with mitral valve surgery with ablation, 63.2%. And nowadays, we have data that reached 80% plus. And this is another study was published in the JTCVS 2018 about the long-term survival with concomitant surgery. So the patient was stratified into 3 groups: Cox-Maze 4 for the patient with AFib, or patient who had an AFib unaddressed during surgery, on the patient without AFib. And you can see here the difference is significant in favor of patient who had Cox-Maze 4 in terms of survival. Same thing, the Cox-Maze 4 has superior outcomes over everything else. And there are recent studies all showed improved quality of life, post-surgical ablation, assessed by a certain questionnaire in different journals. And you can see here the red arrow is the very top one, is a patient who had ablation, which is with CABG or other procedures. And then in the guidelines that was published 2017, they did put this mitral valve operation and concomitant surgery as a class 1 indication. And in the most recent guidelines, they did add it does improve the long-term outcomes after so many trials that were published lately. The second part is surgical ablation during concomitant closed atrial non-mitral valve surgery. This is changed from the last guidelines. So concomitant surgical ablation in CABG and or valve patients. This is a retrospective study that looked into more than 20,000 patients between 2008 2015, and the number of patients included in this trial were 2,700 patients, and the primary endpoint was all-cause mortality, and secondary endpoint was in-hospital mortality and morbidity. And you can see the difference is very significant in favor of Cox-Maze 4 procedure. Now this is changed now to class 1 indication. The level of evidence is B, non-randomized, to have a surgical ablation during concomitant closed atrial non-mitral, but not only CABG and AVR, everything else that has first-time surgery, closed atrial non-mitral surgery. Third part is standalone surgical ablation for atrial fibrillation. This is a landmark study that was done in 2017 in the circulation. They did took about 133 patients who have a standalone procedure, minimally invasively, and they did Cox-Maze 3 or 4, and the median AFib duration was 51 months, and the atrial size was almost 5 centimeters. A long-standing AFib patient was 78%, and the patient who had previous catheter ablation was 44%. So the outcomes were success rate at 5 years was 79%, approaching 80%, and the patient were off anticoagulation in after 5 years, 81% of those. And this is one of the studies that was done last year, published in The Lancet, CEASE-AF trial. It's a randomized controlled trial with 146 patients enrolled to compare safety, efficacy, and quality of life outcomes of a combined epicardial surgical plus endocardial catheter technique versus standard endocardial catheter ablation technique for patients with persistent or long-standing persistent AFib. This study aimed to provide evidence for effectiveness of combined surgical and catheter ablation approach as a standalone therapy for atrial fibrillation. And you can see here the freedom from the AFib, atrial flutter, as well as freedom of the antiarrhythmic medications were significantly better for patients who had hybrid approach versus catheter arm. The standalone in the guidelines, surgical ablation for AFib, now it's class 2A indication. So this is for the catheter-based therapy, and this one as well for the Cox-Maze 4 as preferred procedure. The BVI is a class 3 indication, unfortunately, for the patients with left atrial enlargement more than 4.5 centimeters because it doesn't work for these patients. So the left atrial appendage management, everyone aware of this landmark trial, which is LEOS trial that published in the New England Journal of Medicine, and the principal investigator was Dr. Whitlock from McMaster University in Hamilton, and the surgical arm, a patient who have left atrial appendage occlusion, 2,400 patients, and the other patients who did not have it, 2,400 patients, and the freedom from stroke and systemic embolization was significantly in favor of patient who had the occlusion, and here the risk is significantly better for patients with occlusion. So the management of LA appendage in 2017 guidelines, class 2A indication, and the current guidelines, it is class 1 indication with level of evidence of A in 2023 update. So the left atrial appendage obliteration for AFib is recommended for all first-time non-emergent cardiac surgery procedures with or without concomitant surgical ablation to reduce morbidity from thromboembolic complication. Standalone left atrial appendage occlusion. They did randomize. There is a meta-analysis paper that was published 2 years ago, and there was no difference between in 12 months between transcatheter versus thoracoscopic surgical clipping, and there is another studies underway. So now still class 2B indication to do an isolated left appendage obliteration in patients with long-standing persistent AFib, high risk of stroke, and contraindication for failure for long-term oral medication. So patients with AFib under consideration for transcatheter valve repair, this is very interesting. This is a meta-analysis published 2022 for patients who had SAVR versus TAVR. The patient with pre-existing AFib who undergo aortic valve replacement have a greater risk of mortality and major complication following the procedure. And the complication much greater with patients of TAVR versus SAVR. And this is basically out of 400,000, 39,000 patients. They did 2 match groups extracted from this population. The SAVR with surgical ablation, the number of patients was 2,500 patients, and the TAVR alone, 1,000, almost 500 patients. They excluded the patient with high risk score. So primary outcome was all-cause mortality, and secondary outcome was stroke, TIA, pacemaker, implantation, bleeding, rehospitalization. And here is the outcome. So there is a significant difference between the 2 groups in favor of SAVR. So all-cause mortality following aortic valve replacement was significantly lower for patients who underwent SAVR and surgical ablation compared to those who had only TAVR. And you can see on this on the left side the number of patients of TAVI in 2012 and nowadays how big it is. But for the low risk or intermediate risk patient who had an AFib, please refer the patient to surgery because they have better outcomes. And there is a mortality benefit for that. So all these TIAs, stroke, pacemakers, bleeding, rehospitalization, all was significantly better in favor of SAVR. And they come up with these recommendations. So nowadays, patients with AFib under consideration for transcatheter valve in the guidelines, the last guidelines, it is class 2A indication to send them for surgery. And for all patients with atrial fibrillation, multidisciplinary team is very important. We need to collaborate and work together to have better outcomes to help the patients with atrial fibrillation. So Muhammad mentioned lots of trials and papers published in different places. So this is the most recent one, and there is always significant survival benefit for the patients who undergo surgery, multicentral trials, retrospective studies, and meta-analysis. There is significant difference for treatment of AFib with surgery. So long-term outcomes of Cox-Maze-4 here between 2003 and 2018, 853 patients underwent either biatrial Cox-Maze-4 or left-sided Cox-Maze-4. And freedom from AFib assist at 10 years, and it is significantly better if you treat it. There are many trials, actually. So the last thing that I want to talk about today is the surgical ablation in patients with redo. It still has significant benefit, and there is, as you see in this graph, the survival benefit is significantly better, and there is the risk of thromboembolism or stroke is significantly better for those patients. and the overall survival is significantly better, as you see here in this graph. And I would like to thank you very much for inviting me for this National Electrophysiology Symposium.